Good morning, everybody. I'm going to speak to lipids for the neonate with a special emphasis on the preterm infant. I do have some disclosures. I have a research grant relationship with Reckitt Mead Johnson. They're providing product for a currently NIH-funded study on enteral fatty acid delivery. I've served as an advisor to multiple nutrition-related companies, Lactologics, Plaque House, Vitara, and Baxter currently, and in the past, Abbott, Fresenius, and Prolacta. So as you can see, I will speak to anybody and everybody until we get this right for the preterm infant. I'm going to highlight 4 main talking points. I'm going to go over the perinatal transition and fatty acid status after birth and what I call the fatty acid dilemma in preterm infants. I'm going to illustrate the impact about how lipid emulsion choice impacts that fatty acid status, and then introduce some translational science on the impact of that fatty acid status on developmental biology. And I think that's what's unique about what I will be speaking to today is that in neonates, and especially preterm neonates, they're continuing their organ development. They're continuing the development of their brain, their eye. Growth is so important for them. And so their lipid and fatty acid status has to be thought of in a developmental biology context. And then finally, probably we'll be raising more questions than answers. How do we take what we're starting to learn to continue to innovate and optimize what we deliver to the preterm infant? So the fatty acid dilemma, the perinatal transition and fatty acid status. Long-standing, excellent resources that have been established already in understanding that fetal acquisition of lipids and fatty acids, and then what happens postnatally. And so there's something called selective biomagnification of DHA and ARA that occurs largely in the 3rd trimester. So if you look at the first panel on the left, what you see is on the x-axis the DHA percent of circulating phospholipid in the mother as well as in the fetus. On the x-axis is advancing gestational age. At approximately the late 20th week of gestation, almost 30 weeks of gestation, you see an acceleration, an increased accrual of DHA percenting in the circulating phospholipids compared to mom. That's why it's called this biomagnification. Fetal stores begin to exceed that of what is in mom. In the middle panel, they start to look at the placental transfer and what that looks like specifically for DHA and ARA. And again, this has been well studied. This does not happen for other fatty acids. It is selective for this. So it tells you that DHA and ARA is important for fetal development and also infant development. When you look at the ratios of DHA and ARA of the fetus to the mother, and especially in the adipose tissue, you see that DHA is about 10 times greater than that in mom, and ARA is 90 times greater. So again, not only does it speak to the biomagnification, I think it also hints to the ratio and the relative balance to these 2 fatty acids that we may want to consider maintaining as we move forward in the postnatal period in the preterm infant. The last panel illustrates the importance of adipose tissue, and adipose stores as a reservoir for these fatty acids. And so we often think about these fatty acids being important for retinal development and brain development, but if you look at the accrual and the accrual in orange, that's the accretion that's occurring in the adipose tissue. This serves as that reservoir after delivery when the umbilical cord is cut, and it carries over that full-term infant during critical windows of brain development and organ development, not relying on such high transfers anymore. They've built the stores. In preterm infants, and those that have experienced taking care of preterm infants, we know they do not have adipose stores. So they're extremely vulnerable to the day-to-day provision of lipids and fatty acids to maintain any appropriate levels of these critical fatty acids. And so this was the first study that got me completely captivated as fatty acids and lipids and be important in fetal development. I was initially a trained epidemiologist, and I would look at nutrition and growth in general. And I kept reporting that growth is important to their outcomes, but we don't do it well. And finally, challenged by an adult colleague in lipids, asking me, what do we know about the lipids and fatty acids in preterm infants? And I had no idea. And I knew at that point that if I was going to understand and optimize nutrition, I had to understand mechanism, and I had to understand composition of what we're delivering. So in this study, this was 88 infants, less than 30 weeks of gestation, with a background of 100% soybean oil for our lipid at that time. And then what you see in each graph, and so we'll start with the one on the left, which is illustrating what happens with DHA. The x-axis is the mole percent, the y-axis is the mole percent of DHA, and the x-axis is time. I looked at time of birth, 1 week, 2 weeks, 3 weeks, and 4 weeks. The red dotted line is because I didn't know what to expect and where they should start. So we also looked at 10 term infants who were otherwise well. And what you see in the DHA graph is that at birth, both term and preterm infants are sitting at around 7 mole percent, which is extraordinarily high, again, speaking to the importance of DHA in fetal and infant development. But by 1 week, and if you were to actually do it by day, it's probably even by day 3. But by 1 week, you go into this DHA deficit. You see that the DHA level sort of dives down, and then subsequent to that, kind of stays steady. So it didn't matter how I fed them afterwards, giving them breast milk or anything. Once that deficit occurred, it remained. If you look on the right, that's the arachidonic acid and the linoleic acid. And so LA almost triples from that of birth, and arachidonic acid has the same pattern we see in DHA, where by 1 week, you're creating this deficit in arachidonic acid. And our current nutritional practices do not help this situation. And why is this important? Because when we went on and looked at this cohort and examined, does this matter? There's a lot of postnatal transitions that have to occur. Was this biologically important? So for bronchopulmonary dysplasia and chronic lung disease, every 1 mole percent drop in DHA, the infant was at a 2.5-fold increase in developing bronchopulmonary dysplasia. That's lung injury requiring oxygen out to a postmenstrual age of almost term or 36 weeks or greater. If you look at the arachidonic acid, every 1 mole percent drop in arachidonic acid, the infant was at a 40% increase in late onset sepsis. We also saw for both, with an increasing LA to DHA ratio, it increased the risk of these two morbidities. So I like this because there was a bit of selectivity about which one was important for each morbidity, which I think speaks to the fatty acids and the complexity of the fatty acids. But it also spoke to the importance and the biological importance of these diseases and how they relate to fatty acids. So as a clinician and thinking about how are we going to fix this situation, I think the understanding that fatty acids changes occur rapidly. So within that first week. And also, if you've spent some time in the NICU, you know that we advance enteral feeds very slowly and cautiously. So right now, I don't think there's an enteral strategy that can meet these needs and prevent these postnatal deficits. Maybe in the future, something we're trying to think about. But if we want to think about an immediate way to prevent these deficits and help the developmental biology and reduce morbidity, it's an opportunity that we must do within the first week. And thus, it's really the parenteral lipid emulsions that we need to think about. So what are our current options in the provision of parenteral lipid emulsions? And when I speak to this, I want to be clear that I'm speaking about maintenance nutritional delivery. I'm not speaking about unique conditions, later term conditions, morbidities that might need a specialized lipid emulsion beyond what I'm speaking about today. I'm speaking about the maintenance nutritional delivery and what lipid emulsion should we be using. Beautifully, in the 2 prior talks, we heard about the importance of lipid delivery in adults, and it's similar to neonates. Providing lipids is not an option. It's a rich, energy-dense source that we need to provide to optimize growth. We need to provide it to minimize essential fatty acid deficiency. And it is also helpful to provide it as a balanced macronutrient delivery to prevent hyperglycemia. So all of those principles remain the same, and this is why we need to consider this early in providing this nutrition to our infants. In this table are published ASPEN guidelines, and you've also already heard about the different lipid emulsions and the different components and the oil sources for them. I just want to say that in the United States, the olive oil, soybean oil combination has not been approved for use for pediatrics. But you'll see that the dose pretty much for both preterm and term infants lands at about 3 grams per kilo per day. A kind of controversy about how fast you start and how much you should ramp up each day, but I would say most units will get to that target of 3 grams per kilo per day within 2 to 3 days. I wanted to show this not only because of the different oil sources, which you've already heard, so I don't want to repeat that, but more on the bottom half of the graph, so that you can understand sort of the fatty acids that compose each of these oil sources. What's the fatty acid that we see in the soybean oil? What's the fatty acid that we see in the MCT oil? Thank you so much. What's the fatty acids that we'll see in the olive oil and in fish oil? So if you look at the soybean oil, it's dominated by the linoleic acid, and it explains, right? It explains that when we provide a soybean oil, why immediately we get this tripling in the linoleic acid level. And so some of this is iatrogenic. You know, we are perturbing these systems with the practices that we have. And so with that linoleic acid, you would expect that with the total amount of soybean oil content, that the levels of linoleic acid will be reduced. And then I think the other part of the table I want to focus the attention to is the arachidonic acid, the EPA, and the DHA content. And you'll see that as you go to the multi-component fish oil and the fish oil, 100% fish oil emulsions, you'll see this increase in the arachidonic acid, EPA, and DHA content. And I'm going to show you a little bit about what we're observing as far as what happens to levels after infusing those lipid emulsions. The other thing I want to point attention to is the ARA to DHA ratio. I hope over time and the rest of the talk I'll sort of convince you that the arachidonic acid content and levels are extremely important. And I've already mentioned how in the fetal period it really outstrips what we see even with DHA content in the fetal period. And so with the emulsions, with the fish oil containing emulsions, we see that the ARA is a much lower content relative to the omega-3 or the DHA and the EPA. So one of the first studies I did after that clinical study is I just wanted to understand the impact of our practices on these fatty acid levels. This is a preterm piglet model where after delivery we placed some central lines and we gave them various lipid emulsions. And then we measured the levels over time. And what you see here is this is the final levels after a 10-day period of emulsion delivery. Again, on the y-axis would be the mole percent of that fatty acid. Along the x-axis, I put it sort of in order where the N6 dominant soybean oil is on the left, all the way then to the right, which is the 100% fish oil, and in the middle are sort of the multi-components lipid emulsions. And what you see is for linoleic acid, just as you would expect, is that the lower the soybean oil content, the lower the postnatal linoleic acid levels. The red dotted line that you see in each of these graphs are the birth levels. So it's a reference point of perhaps where we should target. For arachidonic acid, despite having some content of arachidonic acid in the multi-component fish oils, we see that there is a drop in arachidonic acid, as in soybean oil, but the drop is a little bit more when using the multi-component fish oil. Moving on to the N3 pathway, you see a DHA increase, as you would expect, but you also see an extraordinary high increase in EPA. and EPA comes coupled with that DHA in these fish oil-based lipid emulsions. For the preterm infant, the effect of that is unknown. I know it has tons of benefits for the adult population, or at least what's been studied as perhaps anti-inflammatory, helping with hypercholesterolemia, helping with platelet stickiness, all the things to protect cardiovascular health. But those are all things that we may not want in a developing preterm infant, where cholesterol and triglycerides are very important to the developing brain and other organs. On the right is the overall N6 to N3 ratio. Again, thinking that with arachidonic acid and some linoleic acid, it's important in fetal development. And it was the soybean oil that sort of maintains that a little bit more so than the multi-component or fish oil containing lipid emulsions. The preterm piglet model is a very good model for what happens in the infant in the postnatal period. So not every study will have fatty acid levels, but when they do, we see something very similar. And so in this study, this was a soybean oil versus a combined MCT, soybean oil and MCT with a multi-component fish oil. And again, you see an increase in DHA, but you notice we still don't have it so that we don't reduce that early postnatal deficit. But later, where they're resting, the DHA content is higher, but look at the numbers on the y-axis, it's only about 0.4 mole % higher, interestingly, and only about a 2% change. Arachidonic acid, you see again that the fish oil containing component, lipid emulsion, drives that arachidonic acid lower than the soybean oil component. And again, looking at the axis, it doesn't look like it's as to the same magnitude of DHA, but it's actually down 2 to 3 mole %, or about 10%. And then the EPA, again, extraordinarily high from baseline, with an unknown impact on what that does to the fetus or the developing preterm infant. So what I think is happening here is that despite the content of some arachidonic acid, I think the relative component or amount of arachidonic acid to the DHA is probably not enough. But with the high EPA, the EPA we know can be a negative regulator to arachidonic acid production as well as cellular membrane incorporation. So fish oil containing lipid emulsions, I think, do exacerbate the ARA deficit, and I will proceed to tell you why. I think that's a critical point in when we're discussing lipid emulsions and how we can continue to innovate from here for the fetus and the developing preterm infant, and that the increase in the EPA, I will admit, is theoretical, but has potential concerns in a developing preterm infant. So arachidonic acid is considered conditionally essential. There's a really nice article that someone wrote called The Essentiality of Arachidonic Acid. And so we can't forget that for the developing preterm infant. We know it's important for growth and neurodevelopment. Early formula experiments, when they were just giving the DHA, found an impact on growth, and it was until they added the ARA that we saw improvement in growth. It's the primary fatty acid in the brain until almost term, which I'm not sure if anyone or everyone realizes as well. This is a graph from a Martinez study that looked at fatty acid in the cerebral, I believe this is the cortex, and saw that the arachidonic acid was much higher than DHA until almost term. And this is the period of time that we're taking care of the preterm infants in the neonatal ICU. I showed you earlier with the clinical association of a reduced arachidonic acid increasing nosocomial sepsis. I'll show you data where a reduction in arachidonic acid has been linked to the increased risk of retinopathy of prematurity. And I'll also show you more data about arachidonic acid lipid mediators and the importance of organogenesis. But before, I want to go into that data, that biological data that I've been accruing. But as I was struggling through this data and realizing this compromise in ARA, I think is important, I was seeing sort of a shift in the use of lipid emulsions in the United States, where primarily it was soybean oil, and then with the multi-component fish oils, there was an adoption to using that as a maintenance therapy. And I do think some of that came from other literature showing that fish oil containing lipid emulsions was very important for preterm infants that had acquired liver injury or PN-associated liver disease or sometimes what we call PNAC. So I kind of get, we're worried about that and we want to make sure that doesn't happen, but that was being adopted very early as maintenance therapy. So at a recent workshop that I was holding in Arizona, about nutrition, I just generally ask, why are you using in your unit, if you are, a multi-component fish oil as a maintenance therapy? And so the biggest answers, or the top 3 answers, were this perception that the omega-6, L-arachidonic acid, is pro-inflammatory. We're always worried about inflammation, even in the neonates. The DHA is good for neurodevelopment, and they wanted less PN-associated cholestasis or liver disease. And I said, okay, let's go through each of these one at a time, and I'll share some of the translational data that helps informs these general concepts of the use of picking, how they pick the lipid emulsions. So I'm going to call reason 1 a myth, that omega-6, especially arachidonic acid, is pro-inflammatory. I think that's an inherited knowledge from adult studies that we sort of carry with us. But again, in a developmental model, this is incorrect. ARA is pro-development. It's critical for early innate immune responses, and both DHA and ARA are associated with regulating inflammation in a good way. And again, for pro-development, I point you again to the Martinez study. It's one of the most dominant fatty acids in the brain. So this is when I started to go into the translational science and said, okay, if we saw these relationships with lung injury, is there a potential mechanism or strategy to mitigate bronchopulmonary dysplasia or chronic lung disease? This is a mouse model of hyperoxia-induced lung injury. It replicates what we see on pathology in preterm infants with chronic lung disease. So if you look on the right, the inset, on the top left is the histology after being exposed to 90% oxygen for 10 days. What you see when you compare that to room air, which is in the yellow inset, is the alveoli, which are supposed to be very small, are now big. It's called arrested alveologenesis. And what should be very paper-thin-like interfaces between the alveoli to help support gas exchange, it is now thick, filled with inflammation and fibrosis. When giving a DHA-derived mediator, Resolvin D1, you see on the right that interface reduced significantly. So that was good. And it was doing it from some markers of anti-inflammation. But no difference in the alveologenesis, no difference in the structure of the alveoli. When you gave a mediator derived from arachidonic acid, lipoxin A4, you saw also the paper-like thin interface improve and also reducing some inflammation. But you are also seeing improved alveologenesis. And this completely surprised me because I was operating like everyone else, thinking about fatty acids and inflammation. And when I saw this, that made me an arachidonic acid fan. I was like, this is important. This is alveologenesis in the lung, which I don't think had been described before, whereas we mostly speak about it in the brain as far as organogenesis. Another pro-development, this is the also a mouse model, and I wanted again understand what happens when you shift to omega-3 versus an omega-6 profile during development. And so here I utilize the FAT1 mouse where you can give the same diet, but the FAT1 mouse can take those omega-6 precursors and convert it to omega-3. So it's great. You're eating McDonald's and you're elevating DHA. And so now I can control for diet, but get a separation in fatty acid profiles. You see the gene map there and the heat map on the left, where again, by day 3, this is the intestinal ileum, you're seeing a differentiation a clear differentiation. So the other lesson, humbling that our nutrition, our lipid delivery, changes the lipidome, the metabolome, the organ sort of composition immediately and differentially based on what you're providing. The significant factors were the two there that we see, the frizzled 5 and the one below that, the EPH, I can't read it from here, H2. They're both important in a Wnt signaling, cellular proliferation increased in the FAT1. Terrific. But you also see a potential compromise, where on the bottom half, the tight junction proteins, the claudins specifically, 3 and 7, are reduced in their expression. Histologically, we saw less goblet cells in the FAT1 mice, and then we also saw lower villus height and villus development in the FAT1. So now this is the second experiment we came across where it impacted organ development in an omega-3 dominant profile, now in the gut and previously in the lung. It's also critical for innate immune defenses. So we returned to the piglet model, our 10-day model with the different lipid emulsions. On the left, we wanted to understand the eicosanoid and oxylipid response based on the lipid emulsion that you're receiving. The different lipid emulsions are colored differently, and you see, again, a very specific induced lipidome based on what you're providing. The soybean oil separates from the multi-component, which separates from the 100% fish oil. On the right, so I think Dr. Diwali said it perfectly, there's a bit of a nutritional armor you want to think about. So I was thinking about that what you feed our babies, it matters how they then respond to a secondary stimulus. So this is what I was trying to test here. So on the right, at the end of the 10 days, there was an 8-hour infusion of LPS. And what you see, and so these markers are the fold change from that 1, 4, and 7 hours from their baseline. Outside of the 1 hour soybean oil fed piglets mounting a prostaglandin and thromboxane response, there were no other responses later at 4 and 7, and no initial response from any of the fish oil containing lipid emulsions in those piglets. And that's where I think you have to think about, is that a good thing or that's a bad thing or something you don't want to see. And when you think about inflammation and you read about the difference between acute and chronic inflammation, you want your body to appropriately respond in that initial attack when there is a stimulus against you. What you don't want is to not be able to turn off that inflammation, and that turns into chronic inflammation and chronic morbidity. And so we did not have a lot of mortality in this experiment, but the few piglets that did die during the lipid emulsion, or the LPS infusion, were those that were receiving the multi-component fish oil lipids. So finally, about increased inflammation, that DHA is associated with lower inflammation, but I would say that both factors are important in regulating inflammation. I showed you the arachidonic acid mediators for the lung. I just showed you the importance of some soybean oil content and a response for an initial bacteria attack. And then here, this is clinical data, secondary analysis from the Hellstrom study, who looked at DHA and AR levels and IL-6 levels immediately postnatal. And they were both linear, inverse relationship, where the higher the levels of both DHA and ARA, the lower the levels of IL-6. Reason 2, I'm going to say is an incomplete truth. DHA is good for neurodevelopment. Yes, it is, but it also needs ARA. I'll go back to my favorite graph. And then the other two studies. The first one on the top on the table was a formula supplementation study looking at ARA and DHA in a 1-to-1 or a 2-to-1 ratio. It was the 2-to-1 ratio of ARA to DHA that showed improved long-term neurodevelopment. On the bottom is a recent analysis of an intervention trial for ROP, looking again at the intervention of providing DHA and ARA supplement. And I thought it was a beautiful analysis because it demonstrates the interaction of both DHA and ARA. DHA was only protective against ROP if ARA was at sufficient levels. And we see that those sufficient levels being above a background of 8.3. So it was only effective when ARA was sufficient. And then reason 3, I'll say, is unfulfilled, and that's the less PNAC. And I think this is maybe one of the primary drivers of some of the early decisions by neonatologists about what lipid emulsion to check or to use. And we saw a beautiful synthesis of data yesterday afternoon by Dr. Robinson, Dr. Calkins. We're reviewing the published data. Right now, cannot say that in a preventative strategy that the use of a multi-component fish oil was actually helpful in preventing PNAC. There was a trial looking at this specifically in high-risk neonates. I see that trial has stopped, and it was stopped early because of the potential, inability to kind of reach their primary endpoint. And so that publication is not out yet, so I don't have further details on that. But I think the important thing here is that even if you consider this as a potential reason, what we're doing is we're universally changing a maintenance practice to prevent an outcome in a very small proportion of babies who may need this therapy. So I think we have to think about that as well. So why is it important? Why am I going into all of these details? And why is it important to get the science right? It's because in preterm infants specifically, maybe other populations, it's not that if we don't get it right, we don't see a benefit and we walk away. If we don't get it right and we're using these strategies, we're creating harm. And so in this study, they were looking at DHA supplementation in preterm infants for the reduction of BPD. And instead, what they found is that infants who received DHA had an increased incidence of BPD and mortality. They had mentioned in their discussion, IV lipid emulsions that are providing DHA at doses similar to those in our trial are being used with limited testing. Our results raise questions about the safety of this strategy. Not too far in the past, another group wanted to say, okay, if we don't give it to the baby, what if we give DHA to the mom, elevate DHA content in milk, and then when we provide that milk to preterm infants, we can optimize DHA, and also for the reduction of BPD. This trial was stopped early because the DHA supplement in mothers, the babies had an increased risk of BPD and an increased risk of severe BPD. So we have to be careful about the strategies we're using, what that's doing to developmental biology. Not getting it right is just not getting it right. Not getting it right is creating harm. And finally, in this respect, in a secondary data analysis, again, I believe from the Hellstrom group, when they looked at a trial that did not show a benefit for the reduction of ROP based on 2 lipid emulsions, when they looked back and looked at the arachidonic acid content, the lower the arachidonic acid, the higher the risk of ROP. So we need to protect our arachidonic acid in a developing preterm infant. I think we have tons of respect for DHA, and I hope we can increase our respect for ARA. And again, I bring the essentiality of arachidonic acid teaching points, but now have added all the newer data to that slide that we just discussed. And it's this conundrum, because we want to reduce inflammation. We know as a pathogenesis that many of our diseases are derived from increased inflammation. But I think doing it in inappropriate situations and this drive to reduce it, what you're doing is you're compromising organogenesis and organ health. And I think that's the balance we have to be careful about in neonatology. So now what? What do we do with this information? Well, I don't think we're there. We have to have continued innovation, and I think that's critical. And we might see, again, in the developmental biology context, it may change over time. But we've learned that linoleic acid is an essential fatty acid. Soybean oil may lead to an excess of LA without the benefit of increasing downstream ARA, and that levels relative to DHA increase NICU morbidities. Arachidonic acid goes through an early postnatal deficit with all the emulsions, I think greater so with fish oil containing emulsions. It impacts organogenesis. It's important for immunity. It's also important for inflammatory balance. DHA, early postnatal deficit. It's not reduced to the degree that we would hope with fish oil containing lipid emulsions. It is anti-inflammatory, but again, excesses in that may be of concern as well in limiting early host responses. EPA, there's a significant excess with unknown impact. And I think we don't know a lot about other fatty acids. Oleic is not really well studied in the neonate. I think to date, it is the dominant fatty acid in human milk. There's some preclinical data where it's important in enhancing synaptic development, reducing lipid peroxidation, and anti-inflammatory. So to conclude, fetal physiology, I think, tells us where we need to be in DHA and AR status for the preterm infant. And we have to balance both, but perhaps arachidonic acid even more so than DHA. Our current practices fail to fix the postnatal perturbations in fatty acids, and it has a health consequence as a result. And when we think about fish oil containing lipid emulsions, we have to remember it contains EPA as well, which might be counter-regulating what our desired impact is for arachidonic acid. Getting our balance wrong is potential harmful. Let's give ARA its due respect. And so this is the acknowledgement of all of my collaborators.